suggest that for a hospital like that, accepting the card lowers their financial viability? Because if you are paying, because don't forget that we were told about 30% of NHIS covers 2 major NCDs. Again, this was said just last week. I think they mentioned hypertension and diabetes. So it looks like a lot of lifestyle disease-bearing people depend on your card.
Yes, that's true.
Okay, so I'm just saying, is it that for them, if they accept the card, it impoverishes them as a hospital? I don't understand.
I honestly
because if the card, if the system is financially viable, why shouldn't they be happy to accept the card? But they accept private cards and they do cash out of pocket.
Bernard, where we want to get to, and I'll be the first to admit that we've had challenges and we want to put those challenges behind us. Where we want to get to is that the card will be so attractive that all the health providers in this country would want to use it. And we are, I think, on our way to getting there. Last year, by this time, we had 1.5 million fewer Ghanaians on the card. Now we are at 20 million. We would, I think, get to 21 million by the end of the year.
Let's be clear. 20 million, does that mean active users of 20 million Ghanaians possess a card? That's not the same thing.
So 20 million who have registered this year to use the card. So every year we do a registration. Every year. So you need to renew. So 20 million Ghanaians actually have the card. So if they fall ill, they can go and use the card. That's what it means.
So they are willing to use the card for this year? Or they may be using the card?
Yes, exactly.
So which means it's possible that more people possess the card. Because, for example, I have a card. I don't think I've renewed this year.
Yes, so you're not part of the, you're not one of the 20 million.
So which I want you to separate usage from card ownership.
I think card ownership is important because they've taken the trouble in 2025 to renew.
But don't you also want to tell us active usage? And also then that gives you a better sense of which areas the card may be functioning. So beyond 20 million, what percentage would you say in a year use it like at least once?
No, so we have all that data.
But we need it.
No.
Why are you giving us only the 20 million top line figure?
Because
we want to know how many people use it.
Because it's more important to be prepared.
But see, because you know there's access, availability, affordability. You yourself explained that there's, you told us there's financial protection, there's service coverage, and then there's
geographical coverage.
Beautiful.
Yes.
So the 20% is geographical coverage.
20 million.
20 million.
Yes.
That's 60% of Ghanaians. What is the service coverage? And in reality, how many would you say if they went to a hospital today?
Yes.
It would work for them. I think that number is important.
No, it's important, but you see, it gets a bit conflated, and I'll tell you why. Because some people use it 2 times in the year, 3 times. So I can tell you for a fact that maybe 17 million or 15 million have used it. But then we have to then disaggregate it and say one person has used it 4 times or one person has used it 3 times. So for us, for it to make sense to people, it's about being ready with the card to be able to go to a hospital or a health facility and be able to...
All right.
Yes.
We'll deal with more numbers when we come back and also look at a model for financial viability of our health service, including NHIS, but Mahama Kes and the rest of them. Dr. Dr Bampoe is our guest. This is the point of view. Stay with us. We're still here with Dr. Victor Bampoe, who's the Chief Executive Officer of the National Health Insurance Authority. He's been in this position since January. He's done 10 months. He says for the first time we've crossed 60% coverage. He also says that now payments are more regular. Usually in our news cycle, facilities threaten that they won't give people service because they've not been paid. Are you saying that now you pay arrears within months so that today is November 26th? That a facility would typically be paid, would have been paid for September 2025 already? So
they have 90 days to submit.
Okay.
You know, so sometimes they don't submit on the month.
Okay.
Some would have submitted for August by now, some for September. You know, that's the way it works. So there's that 90-day cycle. But as soon as they submit, within that month, by the end of the month, they are paid.
Wow.
But yes, so it's something that has not happened before. And that's why I was saying thank you to His Excellency the President and to the Minister of Finance and the Minister of Health, because we do have the resources to make sure that they pay. What it then does for the health providers is that it gives them some kind of predictability. Like I said, you know, in past years, you would have the private, especially the private health providers associations, going up in arms and saying that they need to withdraw services because they've not been paid. That is not happening anymore. And long may it continue.
A month ago, the MP for Wejak raised an issue that some facilities were not getting access to health care because there was a certain software or a database that was not accessible to them. I think they call it the NHIS.
Yes.
And for that reason, a number of facilities that were to give service to people were not accepting the people. They were doing slow, whatever. What is the status of that? Has that matter been resolved? And have the facilities been able to basically onboard people?
So this is a classic case of being a victim of your own success.
Okay.
So what it is that the Lightwave system is an e-health system that was supposed to offer connectivity to all the health facilities. And we were hooked onto it so that claims were done or are done through that system and come electronically to us. By the way, over 99% of our claims are vetted electronically. Back in the day, it used to be
manual.
paper. Yes,
So
and it was very
much
tedious.
Yeah.
So remember that before this happened, we used to have systems by which we could, because you need to verify that the patient is who he or she says they are and all that. So there are ways by which you can use telephony and other means to verify. This has made it easy to verify the patient and then to submit their claims. So once there was this issue with Lightwave and it went down, it was a bit difficult for the health facilities to go back to the systems that existed before. And it took a little bit of time. And so we had to go out there, get all our staff to go to the health facilities to do two things: to remind them of the system that was there before, to remind them that even our system, the Claimit system, there is a user profile on their system that they can use. And thirdly, to guard against the cash and carry that we did. Because it is easy for someone to say, look, it's difficult for me to submit my claim, so you pay money. And all sorts of people, we are not angels, would use that as a platform to take advantage of patients.
So the Lightwave Health Information System not working, your contingency measure was to send your officers to the facilities.
Our contingency measure was to get in touch with all the heads of the health facilities to remind them of the methods they were using
prior to the Lightwave.
Exactly, which still work, and to put the people who work at NHIA at their disposal to help them if they were having challenges, but then also to safeguard the members.
This information came out a month ago today, 26th October or so, was when your team put out your organization put out a release about the temporary hitch.
That's right.
So as we speak, are there any facilities that are doing out-of-pocket because of the Lightwave matter?
It would be presumptuous of me to say no, but nothing has come to our attention, and we're monitoring very actively because we think that to a very large extent the situation has become normal.
Because of your intervention to remind them of the way they used to work before, because as I speak to you, I think this week there was still a story about Lightwave. The dispute hasn't been resolved.
Yes, but there's a new system in place. Now let us put this in context.
Okay, please do.
Lightwave was supposed to cover 900 health facilities. I think 400, that's in dispute, but I think 450. Now we have over 5,000 facilities. So we are talking about a subset, albeit an important subset.
Fair
so
enough.
I always like to ask
people
to remember...
population. So we have 5,000 facilities, about 500 were affected.
Exactly. Fair. But even within those 500, we've given them specific attention to make sure, because like I said, 3 points to my vision. One of them is to curb illegal payments. So the whole office, when I say office, I'm talking about the 4,000 plus staff that we have. I was on the road. I went to the Volta region with my staff from head office. Everybody else, region, districts, making sure that we remind them of the way that things used to happen before Lightwave and making sure that we safeguard our patients.
So going forward, and this may be a difficult question for you to answer, but is it not better for you to have your own system than to depend on a third party? Because Lightwave is obviously not a government entity, right? And you are providing a public service, and a private company. Of course, the district has told us that this may have risks. So if they were to ask what's the best way to ensure that we're able to get the hospitals functioning better, record your claims in a way that is transparent, would you advise that they use a third party like this?
So I have a lot of things to say about this, but it will be mission creep. So suffice it to say that I think there's a new system in place. There were issues with the governance of setting up Lightwave, and I think that under the leadership of the minister, these have been corrected. There's a lot of merit and a lot of advantage to using that e-health system because it made things very quick. Some of our innovations are based on that, the e-pharmacy and so on. So it's a good system. We just need to safeguard it so that the mistakes that were made are not repeated. So classic case of not throwing out the baby with the bathwater.
Every week, when somebody talks about a healthcare condition, I hear inevitably an appeal for NHIS to cover. So last month or so, Speaker Bagwin met autoimmune people. Please, we beg, autoimmune and whatever, let NHIS cover. Another week we hear dialysis, NHIS should cover. Cancer, NHIS should cover. I want to first understand, do you have a list of official conditions covered?
Yes.
Is it possible for us to mention some of them?
Yes.
And then also, how realistic are demands that people make that add this one or the other? Almost every month I hear a new one.
So it's within their rights because, going to universal health coverage, illness has always been with us and illnesses will always be with us. So that's, I think the issue is about focus. I talked about Mahama Cares, for example, and the fact that non-communicable diseases are now taking us away, causing mortality. So there's a focus on it. I also talked about free primary health care and some of the things, So it's okay for autoimmune and others to advocate for it. What we do is that we have a process by which we look at what is the conditions. I remember someone approached me, a group approached me about lupus and so on, and fitting it within the right context. Nominally, we say the health insurance scheme covers 95% of all disease conditions. That's what traditionally...
Nominally?
Yes, that's what we say. But in reality, there are some that have been left behind. And it's not because maybe 20 years ago when the scheme was being put in place, some of these diseases were not
prominent.
Exactly. So things are changing. The important thing is for us to change with the times and to be able to pivot to meet some of the new realities and sometimes even be ahead. And that's why Mahama Cares, for example, is a beautiful idea because it's, and to my knowledge, it's one of the first decisions on the African continent where we are throwing a focus on non-communicable diseases. Now, I'm going to set my own question and answer. People ask, why Mahama Cares? Why is this not put under the NHIA? There comes a time in the scheme of things where you need to throw a focus on particular disease conditions. And I'm talking about specific
non-communicable diseases.
So for example, I'll give you one example. UNAIDS, where I used to work, a UN agency looking at eliminating HIV and AIDS. When it was set up, people thought, but WHO can do the same thing. The important thing is that UNAIDS has shed light on a particular concern, which at some point was killing millions of Africans and other people around the world. So in this case as well, this is a beautiful illustration of how under the president, we're having end-to-end health coverage. So you look at the x-axis as population coverage, and then the y-axis, which is service coverage. So the blue is actually NHIS as it exists.
So the blue is where you control?
Where we control.
Okay.
Now, if you look at I talked about the fact that 45% of conditions are now under chronic diseases. That's why the Medical Trust Fund or Mahama Cares was set up, to close that gap. Now, if you want to turn off the tap when it comes to non-communicable diseases, then you must be catching them early.
All right.
That's where the free primary health care comes in. Preventive, promotive, diagnosing some of these illnesses quickly at the lower centers of health. So we have what we call end-to-end service coverage. We have population coverage where we are trying to get to 100%.
So free primary health care is at the base.
It's at the base.
And this is mostly at the lower level facilities.
CHIPS compounds, health centers, maternity, and even the polyclinics. That's free primary. NHIS is the regular health facilities. What the Medical Trust Fund is doing is providing the training, the equipment, and the general environment for some of these non-communicable diseases to be taken care of.
So does that mean that if Mahama Cares works, it will put less pressure on you because it's raising funding for diabetes, for the so-called, now we have a double disease burden, as they say, the higher level lifestyle disease.
Yes.
So is that sort of taking some pressure off you?
You mean when it works, not if it...
I mean, yes.
So
that it's because you have a funding mechanism for the blue.
Yes.
And he is raising funds for that through a different means.
So it's the same funding for health. You see, so the 3.4 billion, for example, this year.
Yeah, capping. Some goes to that.
Yes.
Okay. And is it administered through the blue?
No. So it goes directly to...
Because if I go to say, I don't know, give me a hospital, Ridge Hospital, and suspected diabetes, who will pay for it? Will it be this or this?
So you would go with your card
for this. Good.
And then under the regular diabetes management, you could still stay with this. If you do get complications, so you get diabetic retinopathy or nephropathy, which then gives you kidney failure, then you're pushing into that.
So if somebody's on dialysis,
yes,
will they be covered by blue or green?
By green, eventually. But you see,
okay.
but we shouldn't even be too focused on that because it's what we call a continuum of care.
I see.
So you can, once you are covered, that's the most important.
No, I want to understand how the green functions operationally. I know how the blue works.
Yes.
I go to a hospital, I present my card, I'm on treatment. Consultation is covered.
Yes.
Some medicines are covered. Sometimes even inpatient can be covered for certain kinds of conditions. So I want to understand, how will this guy work?
So this guy will work because you've gone under NHIS, now you need dialysis. But you are not able to pay for the dialysis because you know that the chronic conditions, and why this is important is that within maximum of a year, most of the households where people have chronic conditions suffer some
They
pain.
become impoverished because
Exactly.
all the money is going into...
Exactly. So once you are identified, you go into that, you see, and then your dialysis is being paid for. Ultimately, for example, we cannot keep paying for dialysis forever. Then we're looking at where kidney transplants, renal transplants.
So more high-level things.
Yes, but so it's a step-by-step journey of 1,000 miles.
So does the person have to apply to be covered by that? Or once you are a member of this and you get to a certain stage, you get transferred to that?
So once again, I can explain, but it will be good for my sister Obo.
No, because you sit in the center. Because this thing you're doing right now, the blue is in the center.
Yes. And I'll come to this. But so they have what we call patient navigators who will then identify those who need,
to be put on that.
Exactly.
But when you say NCDs, for those who are not health people, let me just try if I know.
So chronic diseases,
stroke,
cancer, renal failure, diabetes, hypertension, and quite a number.
And these are usually, you have to keep going.
Yes.
Because the treatment requires regular medical.
Exactly.
What is the white doing here?
So the white is what I talked about earlier. We would wish for all the population to be covered. Right now we are at 60%. We are pushing against these user fees and the co-payments, where people go and they don't have a beautiful experience because they are asked to pay out of pocket. So eventually, success would mean that the whole of the middle layer is covered by blue.
Oh, so you want to reduce the white?
Exactly.
To
the barest minimum.
Do you have a year in mind when you want to do this? As we sit here now, this is the condition we have. Can you do this in 3 years?
We hope that we can do it as soon as possible.
Wow.
And we have measures in place to try and do that. Yeah.
This is quite interesting. We'll take a break. When we come back, I'd like to